was a real pleasure. It is a real pleasure to be here. When Rob Stackler contacted me, I can't say no to Rob, and so here I am. I apologize for leaving a little bit early due to some other circumstances. So this is a topic that is certainly near and dear to my heart. We've spent a lot of time trying to publish some of our material, some of which I'll show, and a lot of other people's work as well. So we want to present the logic, okay, of unsedated office-based procedures. Why do you do it? Some of the indications for each thing that we do. A lot of video, okay, because we're hopefully getting deep into the scotch and beer at this point, so video is important to keep us all focused. And then if you have questions along the way, I think that's probably better also because I'll be turning into a pumpkin at 8:30. Okay, so if there's one thing for those who are not doing pediatrics that will dominate your practice, it's this slide. This is from the CDC, excuse me, this is from the US Census Bureau. Okay, and what you'll notice, this is time on this axis and numbers in millions of US population. So we're kind of right here at this inflection point, and over the next 20 years, the number of people in the US over 65 is going to approximately double. So we're going to be dealing with a lot of old people with laryngologic problems and sickness and et cetera. So how do we help these individuals? Okay. Furthermore, another, I don't want to call aging an epidemic because it's not, but it's certainly a trend, but we do have an obesity epidemic. So according to the NIH, about 35.7% of Americans, all Americans, are obese, and wait for it, 75% of adult males. So this is the population that we're going to be dealing with. When you multiply that by the fact that those individuals are going to undergo general anesthesia for operations, we have to worry about risk. Okay, so the relative risk of helping someone versus the relative risk of not helping someone. Okay, so obese patients tend to have a significantly higher risk of postoperative, wait for it, MI, wound infection, nerve injuries. Okay, how many people have had a diabetic patient, for example, where you put them in their sleds or whatever with their arms and they wake up with an ulnar neuropathy? Okay, it happens a lot. Okay, urinary tract infections, etc. Furthermore, if they're morbidly obese, that is a meaningful risk factor for mortality, somewhere in the range of about 2% depending on the operation. Okay, so if they have a major operation and they're morbidly obese, there's a 1 in 50% chance they're going to die. All right, so furthermore, we know that with intubation, we know this all too well. Okay, there are more difficult bag mask ventilations, and there are also more difficult tracheal intubations. When they looked at, this is a pretty big series, in individuals who are obese versus not, about a 15% chance of difficult intubation versus a 2% chance in individuals who are lean. Okay, furthermore, you're going to desaturate more quickly, harder to ventilate, etc. Okay, so again, America's 65 and over population is projected to double from about 48 million to 88 million by 2050. And the oldest old, this is the term for those over 80 or 80 or over, is going to triple from now until 2050 to about 446 million people worldwide. And actually, there was an additional statistic that in Latin American countries, that number is going to quadruple. So, yeah. All right, so the risk of general anesthesia with increasing age is also real. Okay, age is an independent predictor of postoperative outcomes. Age and cardiovascular disease co-vary, and that is cardiovascular disease is the usual cause for a bad post-general anesthetic problem. Okay? For example, if for total joint arthroplasties, elbow, shoulder, hip, knee, big study looked at age as an independent variable and found that there was increased risk of morbidity, pneumonia, DVT, etc., and ICU utilization in individuals who are aged versus those who are not. For age and lung procedures, open thoracic resections, there was also an association for individuals using a database where they looked at 30-day morbidity mortality following anatomic lung resections, and not surprisingly, those who were older did worse. One brief note actually on weight with open thoracic resections is those who were morbidly obese and those who were really skinny did poorly. Actually, individuals who are mildly to moderately obese for thoracic resections did better. There was something about it that offered a protective effect, maybe because they're losing weight and they have fat stores, or anyway, I thought that was kind of interesting. Okay, let's not forget about the cost of the operating room. This is a recent paper that generated a number of $29.37 per minute, so that's not cheap. This was done in North Carolina, and when residents were present, the average increase in operative time was an additional 4.8 minutes at a cost of, so every resident only costs us $50 a case, so that's not so bad, okay? Okay, so why do we do procedures in the office at all, right? So it's low patient morbidity, you're unlikely to really hurt someone, extremely low patient mortality. I don't know anyone, Adam or Glenn, I don't know anybody who's died from an office procedure that I'm aware of, okay? Limited pain, good tolerance. They can return to work the same day depending on what they do. Probably has similar efficacy, a lot of work to be done regarding that. A lot of patients prefer it, right? They don't want to undergo general anesthesia. And then we also have an aging demographic, and we also have an obese demographic. And many of those individuals represent meaningful risk if you take them to the operating room for something that you could get done just as easily in the office. All right, what about the contrary? What about the counter argument? Why would you not? The equipment is not cheap, depending on what you're doing, especially lasers. You can have reimbursement problems. There has been a working group that now has official codes for office-based procedures, so we'll be able to follow our results in databases more easily, and we'll be able to have fewer annoyances with the insurance companies because we actually have a code, because until now everything has been a 31599, meaning an unlisted code. So if it's a 99, it's an unlisted code, and you have to argue with the team of insurance people, and that's really annoying. It also takes a little bit of staff, right? You can not really do this by yourself. You have to train those people. You also have to figure out how to do it. Okay, so there are technical challenges. There is that learning curve, and part of that learning curve, of course, is anesthetic management. How do you interact with the patient and apply topical anesthesia in a way that the golden gate of the upper airway will be open to you temporarily so that you can do your thing and then get out. Furthermore, some new technology has driven this transition. We have great distal chip endoscopes for which the cost, as you would predict, is going down. Excellent photo documentation. We have a lot of new injectables. I think last time I counted there were somewhere on the order of 30 different things you can stick into the vocal cord. And then we have lasers, most notably the flexible OmniGuide laser, which some people use, and probably more commonly the angiolytic laser, meaning the 532 nanometer KTP, okay, which can be used for a wide variety of things. Adam and I were just talking about how I even use that for Zenkers. Okay, so what's possible? What can we do? This is an incomplete list. Vocal fold injections, whether with a pharmaceutical like steroid or Botox, or augmentation things like Radiesse, now called Prolarin, collagen, hyaluronic acid. We do a lot of awake biopsies for cancer. If someone has an obvious cancer, you want to take them to the operating room, or you want to just get it done, you can even get it done same day. Laser procedures for papilloma, for rhynchoedema, for leukoplakia, for benign lesions like polyps, pseudocysts. Airway exams, so-called transnasal tracheoscopy. Okay, it's really a transnasal laryngotracheoscopy, but TNT sounds cooler because it's dynamite. All right. Transnasal esophagoscopy is something that's been around for 10 years plus. Very common, very popular. We are now, for idiopathic subglottic stenosis patients, the last 2.5 years, we've been doing office injections of their airway, okay, which probably a certain number of people do here, to reduce the inflammatory condition and help them not go to the operating room at all. Esophageal dilations, et cetera, et cetera. Okay, so how do you get to the vocal fold? You can go through the mouth. Okay, one of the residents earlier was asking me about this. You can go through the nose. If it's a flexible needle, you can use it through the working channel, although you can't put in gooey stuff. You can put in drug, like Botox or steroids, but that's about it. You can also go through the neck, through the skin. So through the cricothyroid membrane, through the thyrohyoid membrane, or through the cartilage itself. Okay, so yeah, you can deliver fillers, lots of pharmaceuticals. We are now doing combo procedures in the office where we will first inject cidofovir or Avastin and then do laser. So you can do all this with the patient sitting in a chair. This is a common setup. This is our procedure room where there's the otolaryngology examination chair. Does that show up? Oh, good. This is a video tower. This was imported from the 1970s from a time travel machine. We've now actually updated this monitor to a more modern one. That's the original pulse dye laser, and that's the Revolix laser. So we brought out all our stuff to show the company. Okay, this is Diane H. She's a nurse who's done about 4,000 procedures with me, and another nurse who worked with us for a while. So it helps to have continuity, helps to have people you know. This is a video of how to apply topical anesthesia to a larynx. This image, this video shows a so-called Abraham cannula being delivered perorally. There's a 70-degree telescope which is recording this image. You have them say E while you apply it. That's called the laryngeal gargle. You do that 1, 2, or 3 times, something in that range. Pretty much you're ready to go. Okay, bounces it around, they cough a little bit. That, along with relaxation strategies, which is beyond the scope of this talk, are extremely effective. Okay, so here's a nice example. Okay, a little bit of it.
What volume are you injecting through the apron?
What volume am I injecting?
A cc or a cc and a half?
Per squirt? No, about a half an ml.
Okay.
About 0.5 mLs of 4% topical lidocaine.
Okay.
Yep, you do that 1, 2, 3 times. So here's a video of someone getting an injection for a very small inflammatory lesion of the lamina propria. On the left side, you can see them moving. This is a Zomed orotracheal injector with a very small 28 gauge needle. And you deliver the medicine and then you get out. That's it. Okay, this type of approach seems to work pretty well in Korea and in that area, in Japan as well. It's been pretty common to use steroids as an office modality for Ranke's, for polyps. It's pretty common to see partial response, but it's not that common with a single injection to see a total resolution of the lesion. So you may need to do it more than once, or you may even need to take some of those individuals back to the operating room in case you don't get the resolution you want. Okay, here's another video of someone with atrophy. This person will get a deeper injection into the muscle. This is for presbyphonia. Again, same orotracheal injector needle, and this is collagen going in. This is Symetra. Symetra is great because it lasts, and I've never once seen an allergic reaction. The downside to Symetra, of course, is that you have to mix it yourself. So you literally have to squirt it back and forth. I don't know if anyone's ever done this. Everything else you take off the shelf, take it out of the box, and use it. This is, so I was mentioning this before to Kathy Remchuk. The people at ProLaren, who made ProLaren Plus, many of the individuals at that company left for reasons that are not entirely clear to me, but they formed their own company and patented a slightly modified version of ProLaren Plus, because it has different sized microspheres in it, and they call it Renew. So Renew is this white paste that looks almost identical. It's half the price and you get twice as much. So that's how they're trying to enter the market. P.S. I have no disclosures. I didn't put that up here, but I have no disclosures. Okay, so here's a video of someone being injected, someone with a cord paralysis, okay, unilateral vocal fold paralysis. They have their proprietary needle, which is why it has that very long flange. It's a bit of a design error, in my opinion, but that's okay. All right, so there's the material going in. You can see in real time it filling up the vocal fold and changing the medial contour. I'm going to put a little bit more in, a little bit deeper, okay, or a little bit farther anterior. You can see some convexity happening there. That's probably all you need. Okay, so cost this is a big issue in today's medical climate. Okay, so if you look at the cost of an office injection versus a cost in the operating room under direct microlaryngoscopic conditions, which is the standard of care, right? There's about a $2,000 cost savings per case to the insurance company to perform it in an office setting, right? You don't have anesthesiologists, there's no OR time, there's no drugs, there's no PACU nursing, there's no nothing, okay? Furthermore, when this was tested, this is a little bit old now, this is 07, the savings were preserved across insurance types. So this was not unique to, say, one type of insurer, but totally false in other insurers. So it seems to be a reproducible phenomenon. Another evaluation of this, so what people have done, okay, this is the in the know part. So if you have a standard office, right, a freestanding office, and you do an office injection there, the patient has to pay for their own injectable. And many patients under those circumstances won't do that because it's an out-of-pocket cost. On the other hand, if you do it at a specified surgery center like an endoscopy suite or the operating room, the hospital is mandated to pick up the cost of that disposable. This is also true for laser procedures. Okay? So if you do it in an endoscopy suite or the operating room, that out-of-pocket cost for the patient goes away. So this is an evaluation of OR versus endoscopy suite. Okay, this should say the hospital costs, the costs of going to the hospital, or for going to the hospital, were actually less if you went to the endoscopy suite. So there are fewer bills to the insurance company if you do it in the endoscopy suite. So that makes insurers happy. The reimbursement was the same for the surgeon if you did it in either spot, except apparently if you do it in the operating room, where there's a little minor advantage for laser procedures only, but it's probably, it's minimal. Okay, and it was obvious that if you do it in the endoscopy suite, that it takes less time. So better for us, right? We're all, surgeons are inherently impatient. We hate waiting. We hate turnover time. It's torture, right? So we like to get her done, as they say in Wisconsin. So, all right, so here's a transcricothyroid membrane approach. For this, you need two people. This was one of our residents, Dr. Choi, holding an endoscope while I'm able to access the cricothyroid membrane, okay, this was an individual who was difficult to do via EMG means and didn't like per oral, so we did it through the neck. There's a needle going through the cricothyroid membrane under direct visualization, up into the thyroarytenoid muscle. Okay, the Botox is delivered. You take it out. You rotate. There you go. Wait for it. Wait for it, Dailey. Yep, you take it out, you rotate it, and then you go into the other side. Okay? So that's one way to do it. Another way, if you look over here, you'll see that there's a needle poking, poke, 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 poke. So that's through the skin, through the thyroid cartilage, and then you pull back a little bit, and you know that you're in the thyroarytenoid muscle. Okay? So pretty accurate and pretty well tolerated, surprisingly well tolerated. I know my colleague at Medical College of Wisconsin, Joel Blumen, does all of his Botox that way. Okay, through the neck, through the cartilage, into the muscle, actually without even looking. It's a so-called point touch technique. So no endoscope, no nothing. Through, inject, goodbye. Okay, focal fold biopsies are useful things to do. We see a lot of patients with cancer or with unspecified lesions. So rather than take them to the operating room, you can do it again through the mouth or through the nose. If someone has leukoplakia, this is a maybe, and I'll tell you why in a minute, but if they have what appears to be an obvious cancer, this is someone you want to get done. Okay, this is, for example, a patient who had an endoscopic partial laryngectomy with me, was healing up, but I wasn't sure if this was some leftover cancer or some granulation tissue. That's a per-oral curved biopsy forceps. Turns out it was granulation. That was nice. This is a fresh patient with left greater than right-sided vocal fold surface changes. Very suspicious for cancer. Smoker.
Still smoking.
Stopped 6 months ago. Stopped 6 months ago. Okay, so little nipper. This is the Olympus one, which has actually some serrated edges to it, and you can get one that also has a needle coming out the end of it to plant it in the tissue, and then you crunch it with the serrated edges. It's actually really reliable for getting a cancer diagnosis. So we tried to figure out exactly how reliable, and so for people with what appears to be obvious cancer, all of whom got office biopsies, we got a cancer diagnosis in 85 out of 100 people, okay, 85% of the time, if it's obvious cancer. That's pretty good. And then we picked up another 7-8% when we did a second biopsy. On the other hand, if you really think it's cancer, and you do a biopsy and it doesn't show cancer, you should still see that as a false negative, and you should go back. Okay, so please do not believe that if you do a simple biopsy in the office, particularly with the transnasal one, which is kind of small, you get a negative, it doesn't say no invasive carcinoma. Oh, you're good. No. Okay, don't do that. All right, there was a study from New York City where a lot of people had, there's a huge ENT group there called ear, nose, throat, and allergy. And the primary otolaryngologists there were doing office biopsies and then sent them to Dr. Wu and some of the people at Mount Sinai for further management, okay? But Dr. Wu doesn't really trust those, and rightfully so, it turns out. So he took all those patients to the operating room for full biopsy. Okay, these are for people where it really wasn't clear what was going on. And the number of individuals who ended up having invasive carcinoma was extremely high. So if it's like leukoplakia changes, those people should go to the operating room. If it's obvious cancer, you get your diagnosis, you move on, okay? All right, so lasers are fun. We like lasers. The angiolytic lasers started first back about, 15 years ago, first in the operating room, and then we published the first office laser paper back in 03, 04. A variant of the pulse dye laser is called the pulse KTP. They both have wavelengths that are selectively absorbed by oxyhemoglobin, and so the blood vessels take up the energy and photocoagulate the blood within the blood vessels so that you stop the blood supply, and if you use it up close, it actually microablates tissue. So it's a very controlled ablation. The holmium is a little over 1,000 nanometers and is extremely hot. You'll see that in a minute. I don't have any videos of OmniGuide because I don't use it. Okay, so indications, different reasons to use it. RRP, leukoplakia, erythroplakia, Ranke's edema, granulomas, post-intubation. Okay, if someone comes in with a big granuloma, you'll see that in a minute. You can use it for small ectasias and varices if you want to, but that's not a major reason. Polyps and other subepithelial disease, these lasers have been used pretty effectively for that. So how the hell does it work? So there are probably different effects, and honestly, if anybody wants to do a nice triologic thesis on this, this is waiting to happen. Okay, what are the exact mechanisms that these photoangiolytic lasers use to work? If you, especially with the pulse dye laser, when you were using it and you had it up close to the tissue, you could hear the tissue snap, snap, snap. You'd see it literally blow off. And this was hypothesized to be a so-called photoacoustic effect, where it's the laser energy is actually interacting with the tissue and the air around it to literally blow lesions off. Okay, there's an obvious thermal effect, so you do have to be careful about not frying the vocal cord. There's the angiolysis, which I mentioned, and then this is probably, to me, the most fascinating part, is the unknown biologic cascade. So, for example, when you apply for Ranke's edema, okay, middle-aged, female, large vocal folds, they have a male pitch, they don't like it. You can apply the energy without ablating or blowing up the tissue, and then all you have to do is wait. And you wait a month, 2 months, 3 months, and you come back and the vocal fold has remodeled so that it's much, much smaller. They regain a more normal female pitch. So this is not like, you know, Luke going down the canyon and blowing up the Death Star, okay, where everything just explodes. It's almost like applying medicine. It's like applying drug, except you're doing it with light. Okay, so here's a video of the pulse dye laser being used. Okay, you can see that up close. There's some blanching. That blanching is a thermal effect. Okay, like when you throw your steak on a grill, it turns white. That's from protein denaturation. So that's clearly a thermal effect. But if I were able to play this in slow-mo, you would also see that some of the blood vessels, all the dots, all the blood vascular supply to the papillomatous frons is also being coagulated. Okay? One of the advantages of the KTP is that you can change the pulse rate. So the pulse dye laser could only go about once a second. The KTP, which is one of the reasons it's been adopted, is that you can change the pulse rate from 1 a second up to 8 times a second. So if you have bulky papilloma, yes, this is in another awake patient. So that's right on the anterior surface of the right arytenoid. Pulse, 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 pulse. You can get a lot of work done rather quickly. Okay, so this was a study done from Stacy Hallam's group in Indiana. And she was trying to figure out, well, if we do this, in the office, how are we as surgeons doing? How is the hospital doing? So they did a cost analysis, and there was, again, as far as third-party payers go, third-party payers benefit to the tune of about $5,000 per case. That's kind of a lot, okay? The hospital would also profit about $3,000 a case, so they're still making money, so they're happy too. But if you do it in the office, again, you have to absorb some of the costs. And so they found that if you did in the office, the person who was running the office had to absorb a $500 per case hit, which doesn't really make any sense, okay? So doing this sort of thing in the office really is disadvantageous. Again, looking back at the Hillel-Klein data, probably you should just do it in the endoscopy suite, okay? So this is just a little bit of note on angiolytic lasers. With the pulse dye, you could actually treat the whole anterior commissure in one go and not risk web formation, okay? So one of the problems with treating the vocal folds is developing a raw surface. If you develop a raw surface on one side, no problem. You develop a raw surface on two sides, towards the front, towards the anterior commissure, you're at very, very high risk for web. What they found with the application of the PDL, which I have seen myself, it's incredible. You can treat both sides, and the way that the tissue heals, another trio topic, it makes it so that there isn't a raw surface and they don't fuse together. It's amazing. Okay, so this is a patient with really nasty Ranke's edema on her right vocal fold, and this is back when we were using the PDL. There's no sound on this, but you can see the energy being applied. You don't have to be a rocket scientist also with this, okay? You don't have to be like pinpoint precision, because when the laser fiber fires, the energy comes out as a cone. So it's like you're photoshopping the vocal fold, okay? And one of the titration endpoints for knowing you're done is that the tissue will blanch and all the blood vessels in it will turn dark because there's been intravascular coagulation. Okay, so we reported on this not too long ago in the White Journal on 19 patients, all of who underwent angiolytic therapy. Actually, this is wrong. Some had PDL, some had KTP. But they all had a rise in their pitch, so they no longer sound like men. The vocal folds oscillated more regularly, so the sound quality was better. And if you have vocal folds that are enormous, it takes a lot of pressure to drive them into phonation. And so phonation effort, okay, was a big deal for these patients, and so that also got better. About 85% of them tolerated the procedure, which for us is actually kind of low. Probably it's because when we did these patients, they were all still smoking. I have since gone to a clinical pathway where I won't do it until they have quit for 3 months. And surprisingly, we don't have a lot of fall off of patients. You think, well, you're Dailey, what's wrong with you? Are you an idiot? You're screwing yourself, right? They're never going to come back because they're never going to quit. Turns out not to be true. A lot of them are really motivated because they don't want to sound like men. Okay, this is a wacky one. This is a patient who is shaped more or less like a fire hydrant. Very large, no existing neck to speak of, and had this verrucous lesion on the back of the soft palate that was giving him globus and annoyance and some velopharyngeal insufficiency symptoms. So this is the Revolix laser, which is very hot, and you will see bubbles. Okay, those bubbles are the tissue literally being cooked. Okay, so you can cook it, and then it will fall off and die. This patient got 1% lidocaine injection into the soft palate, okay, because this hurts. Okay, and you give them a bunch of Vicodin and whatever afterwards because it's not necessarily that fun. On the other hand, if you stay within the lesion, lesions don't have nerve endings. So as long as you're not frying native tissue, they actually do rather well. That also applies for papilloma of the vocal fold. This is a patient who came in. This may not have been my finest judgment day, but had a tracheal papilloma that we were lasering in the office. Okay, I may have not medicated myself that morning and decided to do this in the office. But anyway, it worked out fine. The other advantage, of course, is that with someone awake, if something falls into their airway, what do? They cough it out, right? What do we do all day long, right, with, peanuts or, food items, right? We cough it out because we're awake and because we're sentient beings and we want to protect our airway. Here's an example of a holmium laser, okay, being used on large post-intubation granulomas. Again, this laser, super hot. Why is this patient not jumping up and down? Answer, granulomas don't have nerve endings. So you can pretty much have at it as long as you don't get too close to native tissue. So again, apply energy, wait for it to involute and go away. That's all you got to do. Okay? All right, so you can't be a complete cowboy though, although I've just shown that perhaps you can. The larynx can be injured, of course, if you have too much energy on the vocal folds. You can scar them, you can form webs. If you get too close, if you don't manage your energy, you don't want to fire into water or blood because that will superheat it. And also, obviously, if you miss, if you're off target and hit something you don't mean to. All right, and one thing about laser procedures is you can't get as much done as you can in the operating room because in the OR, you have all day if you want to, right? You just turn up the gas and cancel your whatever and operate. But in the office, there's a time window, okay? It's sort of a magic trick, okay, in terms of convincing them that their upper airway is should not be as reactive for a period of time. Okay, for transnasal esophagoscopy, this is, again, rather common. It's unclear what the right indications, honestly, are for T&E. There was a paper that just came out, headed up by Mike Pittman and other people, including Dr. Rubin, who's in the room, looking at some of the findings in individuals, okay, who have undergone T&E. So one of the outcome measures, and correct me if I'm wrong, was findings that constitute a change in management, okay, FCIM, or I think that's what you called it. Findings were more common. Things like Barrett's, esophagitis, or stricture were more common in males and obese people, and people with a history of head and neck cancer, and if one of their primary complaints was dysphagia, right? Because they might have heartburn or hemoptysis or who knows what, right? Or globus. So we don't know the right answer yet, but this is one step in that direction, so I thought that was a valuable contribution. Okay, this is a silly video of a normal esophagus looking at the mucosa. You do have to use, one technical tip, a fair bit of insufflation, but you don't use constant insufflation. You puff, and then the esophagus relaxes, and you see a peristaltic wave, and you follow it down. So it's a couple of puffs, follow it down. A couple of puffs, follow it down. Let the esophagus do the work. Okay, and then the dynamite, okay, the TNT. In residency, so first of all, about 85% of what I do now, I never learned in residency. And a lot of, honestly, this stuff has been sort of self-taught or because I'm just kind of frustrated and want to do something different. So when people came in with stridor, okay, not, stridor, but not in acute distress, wouldn't you want to know what's going on in their airway prior to taking them to the operating room? I never understood that in residency. Like, we're just going to go and we're going to do what? So what's the plan exactly? So it allows you to see and know what you're dealing with prior to going, okay? So stridor without known cause, so you can find out what the cause is in the office. That helps with your preoperative planning. And then also you can monitor your postoperative results. Boy, they're feeling better, let's have a look. You can, okay? And then for people with vocal cord dysfunction, who you think maybe don't have vocal cord dysfunction, maybe they actually have subglottic stenosis, okay? You can look as well. All right, so here's one airway exam of someone, this is past the vocal cords, now looking at the proximal trachea. This individual had had a prior tracheotomy. This is a so-called A-frame deformity. This is anterior, this is posterior. They're left, they're right. That is a narrow trachea there. This patient had biphasic stridor, and we were able to sneak past, okay, to make sure there's nothing else. And indeed, there's not. That's a nice, open, straight airway all the way down to the carina. Okay, so we knew darn well what the problem was, which helped with planning. This is another individual, we'll write this up actually, but this lady is, she came, I've had several patients with idiopathic subglottic stenosis come to me pregnant. Raise your hand. Glenn, Adam, yeah. Fun, it's awesome. Not, okay, it's awful, right? Because you're having to deal with them, and then you're also worrying about their kid about to be. It's very challenging. So the standard plan for them is to wait until they're in their second trimester after organogenesis has happened, take them to the operating room, dilate them, and then hope that that's enough to get them through delivery. So we did that. We waited until she was 21 weeks. No, I take it back. She was about 14, 15 weeks. Yeah, beginning of second trimester. Went to the operating room, dilated her. She comes back 6 weeks later saying she's getting worse again, almost back to pre-dilation baseline. Now what? Okay, she's about 270 pounds, about 5'2". Right. It's water weight, yeah. So, so what we started doing is steroid injections in the office because she's a very poor surgical candidate. She would be difficult to ventilate. She might be difficult to expose. And so she's had 4 or 5 injections in the office and now basically, especially since she's not that mobile to begin with, has no airway distress. So you can see she still has some disease, but it's a straight line down to the trachea. It's not a tortuous pathway. It's circumferential, so it's not eccentric, which can create more airway resistance. And she's doing great. And so with steroid injections, we're going to be able to get her through. And this may be all that she ever gets because she's clearly a responder. And we separated these by about 3-4 weeks.
So you did those transtracheally or just
through the nose with a flexible needle through the working channel to deliver the steroid directly into the subglottic mucosa. Okay, so we did write this up a little bit a while ago, just about our basic experience. So with those 68 office airway exams, there's about a 91% patient tolerance. I think we've gotten a little bit better at that with some subtle changes in how we apply stuff. So again, this can be very helpful for evaluation in the setting of airway distress, stridor. I would recommend to everybody in the room, remember 4 and 4. So if you're a resident and someone's having some element of airway distress where they're not exactly about to crump, but they're not doing well, you give them 4 milliliters, 4% topical lidocaine, let them breathe it for 4 minutes through a nebulizer, okay? You know, like people get for asthma in the ER. And then you take your small, flexible fiber optic scope, and you should be able to get a very good exam of their larynx and their subglottis and their trachea. Okay, so then you actually have an answer when you call your staff and for yourself, right, what the hell's wrong with this patient? So you can figure it out yourself. You don't have to go to the operating room. Go and look. 4, 4, 4. Okay? All right, so some of our tolerance data, we put together, we haven't looked at all of our data, but we looked, we started basically recording pain scores on the FACES scale, 1 to 10, about, I don't know, 5 years ago, something like that. And so we selected a number of patients, 431 procedures on 299 patients. This is different categories, laser, injections, airway exams. Our total procedural completion rate was 98.6%. Okay, that's pretty good. So we've been able to shift the curve kind of the opposite way. So Chevalier Jackson, right, father of modern tracheotomy, okay, changed mortality from 98% from a trach to 2%. He also changed the mortality of foreign bodies in the upper airway, in kids in particular, from 98% to 2%. So for me, with vocal cord injections, I went from 98% doing it in the OR to 2%. So it's become a total flip. So this is a very interesting time we're living in. All right, so for me at least personally, I've done about 4,500 procedures over the last 12 years, somewhere in the range of a 98% completion rate, all told. We've had 2 admissions, one for a reaction to Restylane, and I did a laser procedure on a pregnant lady with Wegener's in the office. She also had a certain type of body habitus and wouldn't have been the greatest and general anesthesia candidate. Anyway, she ended up with swelling, and I had to actually do an awake trach on her. We later did a cricottracheal resection, and she went on to have 3 kids, so that was nice. Okay, so we have had no bleeding problems, even for people on blood thinners. So that has been published by the UCLA group. They did, I think they report on 1,200 injections with collagen or something out of UCLA, people on Coumadin, people on warfarin. So it's usually not a big deal. Obviously, you don't want to, again, be a cowboy and just root around and do horrible things, but the chances are low for you to actually have an issue. So in short, this is a very awesome time to be in laryngology. Again, this is sort of like the otologist heyday back with stapedectomy and skull base and middle ear surgery and cochlear implants, like when otology just kind of exploded. That's where we are now in laryngology. So there's been a shift back to the office. Reimbursement plays a big role, time, familiarity, how you learn these things. But in general, it's extremely safe, is effective. We will have need for comparative studies between what's done in the OR and the office to prove this, okay? And furthermore, this pathway anticipates the future demographic needs of aging and obesity in a way that really is logical, and you can sleep well at night because you know you're treating people safely. So I really appreciate the invitation. Rob, I know, had to go because he's got a board meeting to do by phone, but it's really a pleasure and an honor to be here. It's really a thrill for me to talk to you tonight, especially as a neighbor just across the lake. So thank you. I'd be happy to answer questions. Sir.
Have you seen any issues with the perk trade? Have you noticed a uptake in problems at the times of past perk trade?
So yeah, for those who couldn't hear, the question is, have we seen problems from perk trades? So yes, I certainly have seen some. I don't know that I've necessarily seen a plethora the way that we as otolaryngologists, kind of say no one does it like us. I'm not sure I've seen a rash. Probably the most common issue with perk trachs is them putting it through the cricoid. So they put it through the anterior cricoid, not actually into the trachea, and then you take it out and they get subglottic stenosis.
Yeah, no, we've seen a lot of these guys, after they were in a trauma situation, they come in and they crack the cricoid ring, or they put it through the cricoid membrane, or they actually put it through the thyroid cartilage.
Mm-hmm.
We've seen plenty of they're going from all sorts of hospitals, and we've seen an uptick in our end.
I see.
So that the mayor off.
So are those patients undergoing like endoscopic salvage procedures or open laryngotracheal reconstructions, or what are you doing mostly?
I sort of.
Good thinking, yeah. That's always the best answer is refer, yeah.
So I'm not seeing anyone healthy enough in that situation to do any of those procedures.
Yeah, I see. Yeah, there's a horrible selection bias with that population because they're all sick.
Most of them have mistake.
Mm-hmm. So one thing, just as this is my own personal plug, so if anybody's actually interested in laryngology, they should certainly interact with people in this room who are doing it a lot. If you do eventually have an interest and want to do a fellowship, certainly come and give us a visit. Another thing which the residents should know about, which we haven't perhaps done the best job of publicizing yet, is that for 50 years or more, people have run temporal bone courses. Why? Because the temporal bone's complicated and you don't want to screw stuff up, right? And you want to learn techniques. So it's an ex vivo training pathway. So just this last year, we offered at Wisconsin an ex vivo laryngeal surgery course. Okay, so it's each spring. This year, I think it's April 8th. So if you're around and you're a resident, you can sign up for it. We give you a discount off the usual price. It's not too far to come. It's a one-day course. It's a lot of fun. Endoscopic, open, peds procedures, adult procedures. There's simulation as well. And this year we're offering something called master classes where you can watch someone really good at it do certain types of particular procedures, small groups, lots of interaction. It's a lot of fun. So something to keep in mind if you have any interest in that. I'm sure I'll be leaning on Adam and Glenn at some point to come and be faculty for it. So that'd be a lot of fun too. Question, yes, sir. Russ.
I know you didn't touch base on it here, but do you have any experience with office dilations?
Okay, so the question is, do I have any experience with office dilations? I assume you mean airway dilations. Yeah. Okay, so because there's this population of middle-aged females, white females, who get idiopathic subglottic stenosis, and because they don't want to go to the operating room, and we know also that dilation works, can you do a dilation in the office? The answer is you can. For balloons that have come out, including Boston Scientific and Acclarent, there are a couple of warning labels having to do with the fact that the balloons cannot be deflated. So having an inflated balloon in someone's airway that you can't deflate basically constitutes an airway emergency in the office. So I have been, shall we say, hesitant to pursue that pathway because of that. And also now that I know that steroids can work, although not as dramatically and as immediately, I'm not going to be the first one to have death in the office from an office procedure. It's not going to be me. Like, I'm cowboy enough to try some new things and, right? But I'm not doing that. No. I know that there are people who do, and God bless them and enjoy, but it's not going to be me. Okay, cool. Cool. All right. Well, awesome. So hopefully we'll see some of you in Badgerland another time.